We'll, we will give it a minute or so before we start, as we wait for others to join. Okay, looks we're right on time, and I'll try and get us started. Good morning, everyone, again. I would like to welcome you all to the People AMR Network and specifically to today's webinar. My name's Abel Ekiri. I'm a veterinary epidemiologist based here at the University of Surrey in the UK, and I'm one of the network co-leads, and I'll host today's webinar with support from our network manager, Chika, as well as the rest of the network team that will be online. I'll run through a couple slides. First up is the agenda for today's webinar. And this is how it will be structured. And there is a bit of housekeeping that I will also touch on. The webinar runs for 1 hour. We'll start with a brief intro lasting about 5 to 10 minutes, followed by the talk itself lasting about 30 to 40 minutes, and then followed with question/discussion, and we'll close it up at the top of the hour. Just a few reminders for us all. Remember to introduce yourself in the chat, and please keep your microphone muted when you're not speaking. And for questions, you can raise your hand, or you can use or post questions within the chat function itself. This webinar will be recorded, and if you're not comfortable being recorded, remember to mute that video option. And the recording will be available at the end on the network page itself. Now, I'll quickly provide a brief background to the network through a couple slides. The People AMR network brings together researchers from several disciplines who are working on AMR to identify better ways to develop, evaluate, but also implement multifaceted interventions that promote prudent antimicrobial use within the community. And in this network, we do focus on the community and people because it is the behavior of individuals and groups that determines antibiotic use. Here is the team that leads the network. The network lead is Professor Sarah Tokenkrine from the University of Oxford. And we have 4 co-leads that you can see here. Professor Gail Highworth, Professor Sue Walker, myself, Abel, Dr. Wendy Thompson at the University of Manchester, and our project manager, Chika. The target audience for our network activities is everyone in communities who are using antimicrobials, and the communities include prescribers of antimicrobials across different health professions, veterinarians, dentists, pharmacists, primary care or GPs, and on the other hand, we have users of antimicrobials in the community, including farm animals, companion animals, but also people across different sectors. Our aim is to co-develop stewardship interventions with people, but also prescribers in mind. And as such, We're interested in identifying those interventions that better support behavior change. How are we doing this? We are promoting research across disciplines and at the same time providing opportunities for collaborations with experts outside different disciplines. And these are some of the disciplines that are listed on this slide. But as we do this, we are integrating a variety of expertise, but also study approaches as listed on this slide. Our activities range from building networks and collaborations to knowledge exchange and dissemination, to organizing workshops for early career researchers, as well as placements for those early career researchers, organizing webinars and events such as this one that we are having right now, but also developing applications jointly within the network members, but also across the different members who are interested in the various topics that may come up. I would now like to introduce our speakers. I'm delighted to welcome Professor Lawul Raka and Dr. Iriri Hoxha. And I'll briefly read the bio of both. Professor Lawul Raka is a chair of the National Program for Antimicrobial Resistance and Healthcare-Associated Infections, and is also the ICARS project coordinator in Kosovo. Professor Lawul is a nationally and internationally recognized leader in AMR reform. He has extensive experience serving on WHO advisory groups, contributing to global accreditation initiatives, and supporting health emergency responses. For more than 2 decades, Professor Lawul has led AMR and infection prevention reforms in Kosovo. Dr. Iriri Hoxha is a lead researcher of the ICARS-supported Antimicrobial Stewardship Implementation Program in Kosovo. He brings over 20 years of experience in healthcare quality improvement, health systems, strengthening and the implementation of evidence-based interventions. His work spans Europe, the Balkans, Africa, and the US. He collaborates closely with the National Institute of Public Health and the Ministry of Health to operationalize antimicrobial stewardship in primary care settings. In this session, both Professor Raka and Dr. Hoxha will share practical insights from real-world implementation, discuss system-level reforms, and reflect on key lessons learned from advancing antimicrobial stewardship in primary healthcare, while offering perspectives from both national leadership and implementation science. Over to you now, Professor Raka.
Thank you very much. Good afternoon from Congress in Munich, ASPID Congress in Munich with 17,000 people. It's a pleasure to be here, and I would like initially to thank Abel, who initiated this presentation of our results with ICARS project, and also ICARS team and my ICARS colleague, and Rizal and Andine, and also Chika for organizing this. So I will try to share my presentation now. Just tell me if you can see it.
Yes, we can now.
Okay. So in beginning, I would like to show some outline. So today, together with my colleague Ilir, we are going to talk about translating AMR policy into real implementation. So the focus of our presentation will be more on implementation lessons rather than results itself, because we are still on the process of the project and we are at the final stage, final year of the project. So this is the title of our project. And we also have a mascot here with a key for antibiotics. And this cartoon and others that you are going to see in my presentation in next slides are part of awareness campaign that were prepared with the best cartoonist in Kosovo. So I hope you will like it, and I'm ready to share all of them, whoever writes to me in my email. So this is ICARS and Ministry of Health project implemented by three partners: National Institute of Public Health, medical faculty, and evidence synthesis group. So this is today's picture in antimicrobial resistance. It is one of the growing and unevenly distributed global health threat, with misuse and overuse of antibiotics, particularly in primary care, as main driver of resistance. And today, many countries have their own strategies, national action plans, and roadmaps, but AMR is not a strategy challenge. It is an implementation challenge more than strategy challenge. So from Kosovo perspective, since this is a global webinar, I think Kosovo is in Europe, in the Western Balkans, has a small population of 1.6 million inhabitants. We have the youngest population in Europe, and we also face, like every country in the world, with a lot of challenges that continue to our effective combat against antimicrobial resistance. In a context, that's why we wanted to be a kind of antimicrobial stewardship implementation laboratory, because it's a small country with manageable health system, with strong engagement of Ministry of Health and leadership for national AMR governance, when clear stewardship needs, especially for upper respiratory tract infection, and feasible to test, adopt, monitor, and implement the real AMS in real world condition. I will start with governance, because without governance, antimicrobial stewardship remains only a temporary project. The other reason is that governance is umbrella covering all pillars of addressing AMR, starting with prevention, diagnosis, and treatment, and also community engagement. So this is very important topic. And in this field, I would like to mention some achievements from Kosovo. So we strengthen governance and legal frameworks, implementing so far 2 national action plans, although with limited support. Then we were last year signed a new national action plan together with ECDC, European Center for Disease Control, with EFSA, which is Veterinary Agency of Europe, and also European Commission, becoming the first country in Western Balkan to adopt One Health approach for antimicrobial resistance. It was signed just a couple of months ago. And also we introduced One Health approach in legal framework from last year, working with all 3 sectors: veterinary sector, environment, beside the health. A few years ago, we introduced Access Watch Reserve approach of WHO into essential medicine list of Kosovo, and also introduced some educational components such as antimicrobial resistance and patient safety as undergraduate modules, translated e-bug in Albanian language, and also are part of global surveillance network. Why we chose the primary care? Why primary care antimicrobial stewardship? Because it is an area where majority of antibiotics are prescribed and used, mainly for respiratory tract infections, which are by origin up to 90% with viral etiology, and they don't need at all antibiotics. The other component is limited diagnostic and behavioral prescribing. So these were the main targets, and also we followed some baseline prescribing challenges, starting with high ceftriaxone use in Kosovo, high percentage of watch antibiotics group, parental prescribing, brand prescribing, and variability between different municipalities in Kosovo. So these confirmed our need to have a structured stewardship intervention. You can see self-medication here as one of important challenges with over-the-counter sale in the country. So primary care is where antimicrobial resistance is either accelerated or prevented. That's why if we want impact, we have also to work to start with primary care. Our targets were to reduce 20% antibiotic use for upper respiratory tract infections, and specifically to reduce ceftriaxone 30% use for upper respiratory tract infections. The project, ICARS project, started in 6 intervention centers and 6 municipalities, main family medicine centers, and also 6 control sites who now became intervention site as well. And key pillars or multimodal interventions involve governance strengthening, workforce training, monitoring, behavioral science, and the scalability strategy. For implementation frameworks, it's an area of Ilir, so he will cover that work. But how we got government on board to work in AMR. Some interesting information that we would like to share is first, for every government, you have to understand the current context, governmental context, particularly in the Ministry of Health. Cultivate a relationship and engage Ministry of Health early in the process, maybe even before the writing of the project. The next, you should have good data-driven arguments, and politicians want to hear more local data than international because they are politicians. And it's good also to share best practices in other countries, telling that it can be, it is doable even in your country, in our country, for example, to shape message effectively, to engage media, also to show long-term benefits, and to be ready to address every potential resistance, whatever it comes from industry or from doctors or whatever, to have answers for that. What was the biggest achievement so far in our project? I think the most important for us was to build structures, not just outputs, and to translate evidence into legal and policy instruments. So what we did with this project proposal initially, we established structure at the national level, at facility level. How we did that? Through establishing Antimicrobial Stewardship Working Group within a national AMR committee. Next, through establishment of a standard operating procedure for Antimicrobial Stewardship Group in every primary care facility. So document was prepared by ICARS group, core group, and it was approved by Ministry of Health. So it was approved even at the first year of the project. And this means that these groups are mandatory not only for 12 intervention and control sites, but they are mandatory for entire structure of primary care in Kosovo. And this is sustainability happening from inception. This was an amazing result that we didn't expect it. And the next one is to include AMS and AMR into legal framework. Here we have, this is so-called vertical scale up, but what we meant by horizontal, we meant by sharing and distributing that approach from main family medicine centers in other centers, smaller centers within the same municipality, from people who were trained and shared that vision in their working areas, because they work in not only in one facility, but 1 or 2 or 3 within the same municipality. The other important component was to break the silos. How to break the silos? This is structure, how we wrote it in our project proposal. We proposed to have 5 people, but in the meantime, during the kickoff meeting, together with ICARS team and representatives, there was an idea, okay, antimicrobial resistance is not only healthcare problem, it is problem for community, because population is consuming without consulting the doctor. So an idea that was shared during that meeting to introduce or to invite every antimicrobial stewardship group should invite 1 community representative decided by municipality themselves, because they know best who is a celebrity in their area. And this approach was approved completely by Ministry of Health and became national document, a long-term document, a living document. First thing next that we did, here you can see a picture in one of the facilities, and this is prescriber commitment declarations supporting antimicrobial stewardship, which was publicly displayed and also signed. At the end, you have names of doctors and their signatures that they pledge to follow the prudent antibiotic prescription. These are some of core interventions. I will not go in detail. I will mention them now. But within that regard, our philosophy was to change system, not only the knowledge. So that was a long-term impact and effect of our project. Capacity strengthening is another important component, and we did with a cohort of 200 participants. You have a training picture on left. On the right side, you have a handbook that we prepared for doctors. It is antibiotic stewardship in primary care, and we shared it during the training with doctors, pharmacists, and other healthcare workers. Another scale up, or how to say snowballing effect, is that from this curriculum, Abel remembers that we had an idea to expand it with international community, and we are now under development from handbook to book, AMR book, with 80 experts, with 40 chapters, and these experts are from 6 continents, and we are happy with that change. We also included antibiotic-free information leaflet for patients who were not prescribed antibiotics to read and to share it with their families. And from the early findings, we saw that we had PPS and clinical audits. So far, we have 3 PPS round cycles with baseline and the other 2 covering more than 10,000 patients. Preliminary results show that there is a beta-lactam dominance in all facilities. There is still high use in some facilities, subtriaxone. There is an aware imbalance and also prescribing variability. But this PPS and the clinical audits, they created a first structure monitoring platform in primary care in Kosovo that will be used as benchmark for every future intervention or additional work on that area. We also realized that from behavioral insight that prescribing is driven by habits, expectation of patients, fear of complications, lack of diagnostics, rather than a knowledge. So antibiotic prescribing is really a knowledge problem. It is usually a system problem and behavior problem. Another important component was international engagement through ICARS platforms. We were able to share visibility of Kosovo, also share the vision of ICARS in international level. And this was very important to exchange our integration into international community of AMR. Ilir is going to talk more about research, but I would like to mention an initial idea from our team was let's publish protocols because every country has a written proposal. So why not publish protocols? So we already published 2 and some others are on the way. Ilir is going to talk about that. Implementation challenges. Yes, implementation is not a linear process. We had challenges which we expected. From some of them, we thought it will go smoothly. For example, administrative and bureaucratic delays from Ministry of Health. So there are delays with rapid swab test procurement. And we also expected resistance to change, specifically following guidelines, national guidelines by some doctors who are close to retirement, because they saw it that they're losing their autonomy, but they are not losing their autonomy. Today's guidelines are evidence-based, not based on 30 years experience. And we also saw that in some facilities, there was no change, no improvement, even after intervention. So we are working closely with them, 1 or 2 of them, to address all, to see feedback and to address this problem. Diagnostic limitations remain, also data systems and also time constraints for that. What we learned for sustainability. Sustainability is not a final stage of a project or even after the project. It is a mindset that starts from day 1. We learned that specifically with establishment of national structure. At the beginning, we asked ourselves, what happens after ICARS project? And we thought about it, and now we are happy that we are on good track to implement, because we already have some of them, legal integration, national SOPs, AMS teams are mandatory, and Ministry of Health ownership. What makes working with ICARS unique? It was really a fantastic experience working with our colleagues in ICARS, starting with co-development approach, which was new for most of us as approach, with ICARS team acting not as distant funder, but hands-on partner, implementing idea to implementation based on or grounded on national priorities and guided by scientific evidence. And this collaboration also transformed the funding into a mutual mission of learning, sustainable change, and even more extended results, such as some research work together with ICARS. What would be our key take-home messages? So start with governance. We started with governance before the activities. Then measure baseline practices. Next, address behavior, not only knowledge of healthcare workers. Integrate stewardship into policy and plan sustainability from the day one. So these would be key messages. And is the Kosovo case relevant globally? Yes, because principles of antimicrobial stewardship are universal and are implementable, but always taken into consideration local situation and local context, and to adapt to those contexts. In conclusion, I will say that we learned that implementation and not paperwork determines whether AMR strategies will succeed or will fail. Our experience shows that sustainable stewardship is possible when governance, implementation, science, and clinical practice are all aligned together. And at the end, these are some pictures from the field. I would like to thank you for your attention. Looking forward for a question after this presentation. Thank you.
Can you see my screen?
Yes, it's coming up. Yeah.
Wonderful. Well, thank you, Lul. Thank you, Chika and Abel. It's such a wonderful opportunity to do this. I'll try and build up on the research part, and also before that in contextualization part, and how we kind of contextualized our project and our studies within existing scientific frameworks, largely embedded within implementation science frameworks. This slide shows the protocol, the overall protocol, which I think you've also seen in the slides shared by Lul. And this is the overall protocol, which kind of outlines the intervention, and also it outlines in pretty much detail what kind of frameworks we used for the implementation, scientific frameworks we used for implementation. And while I think at kind of practical level, one of valuable things about this project has been that it was so well clicked, if I can say, within the existing developments, policy developments with regards to AMR and MS in Kosovo. The other side, I think, which we feel good about, is that we've tried, and I think it feels like we've succeeded in bringing this intervention and operationalizing different frameworks, such as REAIM or CEFIR and other, within the project implementation. So the whole kind of intervention is both well clicked in the Kosovo context and implementation and needs. So it's a real project addressing real needs. And the other thing is we're really kind of, I think, and we've spent a lot of time doing that, clicked it also to different frameworks that I think make the whole thing more valuable, not just for Kosovo, but I think for a broader audience, global audience interested in enacting change with regard to use of antibiotics and reducing the AMR, and also implementing AMS programs that are supposed to reduce that. I'll share a slide which kind of shows the whole project, things that Lul described in detail, but also you'll see different work packages that kind of click in the intervention, which are research components. So as you see, the main component, the intervention component, is the work package 2, which essentially embeds all different elements of intervention, while the initial work was in kind of preparing the grounds, kind of situational analysis. And then the two research work packages of the project are, one is on assessment of barriers and enablers of AMS program in Kosovo, and the other is assessment of economic impact. And the last one is dissemination of results. What I think is valuable, and I will try to present each of the research components, is to maybe focus on the rationale. Why did we choose these particular things? And again, the idea is, or was and is, to choose designs that are not just fancy, but they are also, they are more so relevant for what we're trying to understand. And in this case, since this is the first or one of the most massive attempts to kind of introduce AMS in the country, was to learn, how the implementation goes. And hence we've had the assessment of barriers and enablers. So what is making it easier and what is making more difficult to implement a program like that? And we choose a qualitative study, which is trying to understand what is happening based on people involved in implementation. And then we try to focus on physicians using conjoint design, which kind of tries to assess, but also measure kind of differences in different setups on how these preferences for prescription on particular case of upper tract respiratory infections behave. So what are the attributes? What are the clinical attributes that kind of influence decision? The other package on economic assessment has two components, and both relevant for policymakers. The first one, with kind of interrupted time series, tries to establish both in kind of progressively, but at the same time comparatively between the intervention and non-intervention sites, tries to establish the prescription levels and also to quantify them economically, cost-wise, in order to see if the program is having any economic impact, which is one of the major impacts. So one impact is the health, so we reduce the negative consequences of AMR and antibiotic use in general, in AMR specifically, but the other is what's the cost implications, because antibiotic prescription comes with a cost. The other part was, again, directed towards policymakers. What would be the cost of implementation? So based on the assessment of implementation in 12 sites, we were planning, and we're working on that now, to assess the cost of implementation if we're about to scale up. The project is focused in 12 centers, main family medical centers, out of 36, 38 total in Kosovo. So it kind of, we're roughly covering a third of the country, including the capital, which is a third in itself. Okay, so I'll, one of the main kind of frameworks we used was the REAIM framework, and this is this table kind of summarizes again different components of the studies. One thing that we try to do is to put this within a scientific framework. So we use the REAIM framework for kind of putting the whole project within it. And this is how it looks in terms of the reach, effectiveness, adoption, implementation, and maintenance. And you see that a large part of the project fits in the different domains of REAIM framework. So we use REAIM to kind of shape the whole thing, but then for different components of the project, we used other frameworks. So, for example, in case of barriers to implementation, the qualitative study, which was one of the components of study components, so the total 3 study components, we used Cepher framework, which is an implementation science framework, which is really suitable for assessing the implementation of different interventions. It has, as you know, 5 domains, including participants, the inner setting, outer setting, process, and participating individuals. All of these are kind of assessed in a very structured way. So we thought this is a perfect framework to adapt to our situation, and we did adapt to that. We published a protocol also for this, which is available at BMJ Open. We did that last year. And we developed a research instrument tool, both for the focus group and interviews we were carrying. And here we're targeting an audience of people involved in the implementation, be that as active participants, but also patients as receivers of care, to assess all these 5 domains and understand what was going on during implementation. Actually, as we speak, the data collection is undergoing in different sites in Pristina and elsewhere. In case of this is the kind of setup which we adapted to our project, and you see how this is kind of organized and what's the logic behind it. So in terms of the participants, we have the prescribers, we have the leadership of institution and other technical stuff, and we also have patients who are receiving the care. In case of implementation, what we used was the quality improvement theories, and because largely the approach has been such, and in research we use REAIM, we use Cepher, and another one that we used was for assessing the prescribers' kind of attitude. We used kind of medical practice variation kind of theory, largely.
Would you like me to
Yes?
share the slides? Because yours is a bit blurry. I don't know if I'm the only one who can see properly. So if you're happy, I can share my screen and then I can present.
Yeah, me too.
Okay.
I was going, I thought it's my computer. No.
Okay, that's good. So
Okay,
let me just share.
so
And then
I'll stop sharing.
you cue me
I'll
in
stop sharing.
to click next. Yes.
Okay.
Can everyone see?
So can you do the
Much
next one?
better, Chika, thanks.
Can you do the next one?
Okay, just a sec. Now it's stuck on
So
something. Just a minute here.
no, it's good. The other one before.
Okay.
So one more.
There you go. So
The
this one?
barriers. One more behind.
Okay, behind. Sorry. There you go.
Okay, so in case of barriers, what we decided to do is the physicians are always at the forefront of antibiotic prescription. And so we were trying to kind of understand what attributes, clinical and non-clinical, are affecting their decisions to prescribe antibiotics. So we looked at pharyngitis, so the exercise, the design, the conjoint design, the experiment design was around pharyngitis as one of the most common upper respiratory infections in primary care. And we put in their clinical attributes, such as temperature, fever, presence of fever, but also non-clinical attributes, such as ability to pay and things like that. And this is kind of coming from approach which is largely embedded within Weinberg collaborative and Weinberg thinking, Jack Weinberg, the medical practice variation kind of thing. And among accept supply sensitive care or preference sensitive care or effective care as one of the three types of care he describes, one of the things he's described in his theories is also the kind of physician style, also praxis style. So in a way here, we're trying to kind of assess the prescription style using a conjoined design. This is one of the first time I've seen this done in kind of in an AMS, AMR kind of setup. So we're really looking forward. The data collection will be commencing later this month and will be finished during May. So we're really looking forward to the implementation. The idea, the rationale of this is to see, you know, the practice style and understand it better. And both this as a kind of specifically target toward participant, this is prescribers, and the other component targeted in the whole kind of implementation setup. I think these will give a really valuable information for what to come next and how to design other strategies in implementing AMS in Kosovo, and maybe useful even wider than that. Next slide.
Dr. Hoxha, just a quick mention about time. If we could wrap up in the next 5 minutes so we have a bit of time for discussion, that will be great. Thank you.
Wonderful, wonderful. I think I will be done in 2 minutes. So this is my last slide. So the last of three components is the economic assessment. As I explained earlier, here we're trying to kind of understand both the implementation cost as something that would be valuable in scaling up, and before that, we're also interested in seeing the cost impact of the project. We're doing a cost effectiveness study comparing different moments going forward from start of implementation as going forward, but also the intervention and control sites, 6+6, so 6 intervention and 6 controls, and trying to understand if the program has a cost effect. And with this, we're thinking that this will provide some valuable information to the government in understanding what could be potential cost implications. So this kind of wraps up, at least in this occasion, although we've had other ideas on how and what we could do, but this seemed like the most useful designs we could employ in the existing program that we're implementing with support of ICARS. So the last slide is kind of largely summarizing everything we've done. So this is again, and I thank you very much for the attention that you've provided in explaining these designs and this program. Over.
Yeah. Well, thanks a lot, Professor Raka and Dr. Hoxha, for very interesting and good, useful insights when it comes to implementation of your project. There's quite a bit that you all have covered, and I would like to open up the floor for discussions. If you have questions for Professor Raka or Dr. Hoxha, please feel free to unmute your mic or raise your hand, or post the question directly in the chat, and we can always read it out. Yeah, as we think of potential questions, I have a quick comment, Professor Raka. I thought your approach to the start of the project was really practical, in the sense that you try to engage the Ministry of Health when thinking of the governance role and the legal frameworks that you wanted to put in place. And I was just wondering, from an LMIC point of view, or countries that are way behind in terms of setting up some of these NAPs, the National Action Plans and so on, what are some of the challenges that you did experience or that others can learn from in terms of trying to get a governance aspect working, as in integrating this within your work?
Thank you, Abel. Well, from our perspective, with for low middle income countries, I will share an example that we had with first National Action Plan. It was in 2011. Kosovo at that time was last country to join ECDC program for AMR, but first one to prepare National Action Plan in 2011, 4 years before WHO Global Action Plan. But from government, we got information that we don't have budget, and at that time they had no idea, most of them, what is the importance of AMR. They said, we don't have budget. Okay, stop complaining, look for alternatives. What we did, at that time, there was open call, and today there are many open calls in the world. One of them is definitely ICARS. So we applied an open call of European Commission. It was one call dedicated to healthcare, €250,000 at that time. Everybody applied, and we applied from the Institute of Public Health with a project on antimicrobial consumption and resistance. All activities were part of National Action Plan, and we won that project. And it opened up doors to achieve 80% of activities realized at the end of fifth-year project. Otherwise, at the beginning, we thought without money, you can do some work with passion, with dedication, but you cannot buy the equipment, laboratory equipment with words. So we were very happy for that. And then we kept going. We applied then the WHO, we won another grant. Then donors who were working in Kosovo saw our results. We made them visible, those results, and they were interested to invest somewhere when they can see achievement, feedback, or a kind of rationale for investment. So my suggestion would be never stop asking if you fail once. Of course, failure is part of success. So and today I think we live in a difficult time. World is going crazy. It was mentioned here 2 days ago, with those billions spent in the wars. What could we do with AMR? Imagine with 12 billion in 8 days or 10 days of war. What could the world do with AMR? So it will be difficult, but I encourage all low middle income countries and people leaders in these countries, try, apply. So first address would be like we did recently, ICARS. It's very open, supportive, and you can also learn from each other by peers how to prepare it, how to achieve it. So that is information from my perspective. I would also wanted to mention something that I forgot. I try to reduce my time, but it seemed that I said it. That implementation research and our project as well, sometimes they raise more questions than answers. But this is also learning process. You say, wow, sometimes you don't have answers for these questions. And the other component, very important, I mentioned system, but I didn't cover this by this sentence that, of course, success depends on intervention quality, but sometimes success depends also on health system readiness to accept those interventions. If you don't have interested government or minister, then you will not succeed. From my experience working in this area with some countries in the region, for example, I never had a problem to discuss to ministers. They change very oftenly. But in some of our neighbors, our colleagues, they had to wait 3 to 4 years just to talk about the importance of AMR. So it's changed now. AMR is a global problem, and we should use this momentum to do more, but also taking into consideration that it's important for me to break the silos and to enroll the community. Another important component that I would like to share from now recent experience. I was recently enrolled with WHO in so-called AMR Accountability Index, which is very interesting because it doesn't, of course, it takes in consideration self-reporting. For example, we as a country have national action plan. You have national action plan, okay. Is it implemented? If it's not, it is not accountable. If you share that budget, okay, what is execution scope of that budget? Idea is to test the feasibility in different settings in 6 countries in Europe. Then at the end, in June, I think, in Copenhagen, to decide final structure of indicators that will be helpful to address this problem that we are talking about today, implementation of AMS, initially in Europe, but then they will scale up. It will be global. So this is important component, and it is a tool of pressure to politicians. They will say, "I signed it. You signed it. Did you budget it?" No, I didn't budget. It doesn't exist. Thank you.
Yeah. No, thanks a lot. Hello. Yeah. And we have a quick comment as well in the chat here from Christina. Christina, did you want to read that out yourself?
You would like to share, Christina?
I can do so. Thanks
Okay.
a lot to the Kosovo team for great presentation and for sharing your practical experience. It's very good. I mean, your engagement with the Ministry of Health in particular, but with government overall has been, has been there from start within this project. You managed to maintain their involvement throughout the process from the co-development up until now. Could you elaborate a little bit on how you've actually involved the government and the Ministry of Health, if that has been involving them in meetings, workshops, emails, and considering the competing priorities of ministries, how have you motivated them and incentivized that they remain very actively involved throughout this process? Thank you.
Hello, Christina. Thank you for your question. It was not an easy job, but I mentioned those pillars engaging, enrolling government in these activities. First of all, to see context. Second, to have good communication. Sometimes in our region, it's good to have good connection, or Kosovo is very small, so everybody knows everybody. And at that time, during COVID time, I was sharing a kind of advisory board for Minister of Health. It changed, but I may remain that. And it created a trust, and it was a momentum to use to invest in infrastructure. COVID was a momentum. So we invested in next generation sequencing and in Maldito for PCR for every regional facility. This was one area. The other area that I mentioned data, but data for action. When we enrolled in 12-11 in AMC, antibiotic consumption group with WHO and University of Antwerp, then we got information that we are European champion for ceftriaxone use. And we still have a problem, but at that time, it was huge misuse of ceftriaxone, initially because of pressure from pharmaceutical industry. And I show them the results. Look, to politician, Minister of Health, Director of Hospital, Institute of Public Health, and leader and coordinator for primary care. These are results. We are first in Europe, and we have to change that. So these are data for action. Working closely with them, sometimes it was making pressure publicly in the media. I said, because I was part of that, and I took that responsibility. I said, we fail here altogether. But if you have over-the-counter sale in the country, it's directly governmental work, inspectorate work. It is also mine directly, and my colleagues who work at that committee for antimicrobial resistance, but tolerating that, although it is prohibited by law, you have to implement the law. And responsibility is clear. This is your responsibility. So sometimes once Minister of Health complained that I'm making pressure to him publicly, when Robert was in Kosovo to launch the guidelines for antibiotic use in primary care, I said, it's my job to make pressure. Sometimes it works, sometimes it doesn't work. But yeah, data for action are very important, and also being prepared to address any pressure from outside. For example, when we wanted to enroll this aware approach in national medicine list, which is important, we had some barriers from government, from ministers. They say, is this good? Can some patients have complaints? I said, yes, it's good. Every government uses restrictions, uses different approaches, because the common word umbrella that covers everything is you are obliged to protect health of people. That is number one, and it is included here. Now we will see how it will go with other ministries, because we have new government now in environment and in agriculture. There are new ministers, but they are also interested to hear from academic part. I said, yes, we are happy to share that, to work together with you to explain them why is AMR important also in veterinary sector and environment, and not only in health. So there are several activities. It is kind of a bundle approach, hitting from all the sides together with your team. Somebody in media, somebody in data, somebody in conclusions, in relevant conclusion, trying to improve things. Of course, sometimes it worked. Mostly it worked so far, but there were cases that it didn't work, and it's not so easy with system, because a friend of mine, I will say this, from Canada, when he was 20 years ago, and I remember his word when he said, working for government in particular area is like feeding elephant with enema. It is very difficult, but it takes time, and you realize that it's a marathon. It's not 100 meter sprint. At the beginning, I thought I can run marathon, but I realized, take it easy. It is a long way, so you have to save energy. You have to reorder the team, the group, the ideas based on context to have best possible results.
Yeah. No, thanks a lot.
I hope I answered what Chris.
No, you did. And in the interest of time, we just have one more question that is in the chat window here. If we could have a quick response to that. Yeah. Najis, do you want to read that out, or do you want me to do that? Okay. The question goes, thank you very much for sharing your experience. I would kindly want to ask one question. How are antibiotics dispensed in community pharmacies in Kosovo? That is prescription versus non-prescription, and what impact have AMS interventions at the PHC level had on these dispensing practices?
I think, Lul, you can also do this one, no?
I thought you should also have some questions, but yes, I can answer to this.
It's fine. I mean, it's perfectly fine. So,
yeah, from this perspective, I mentioned that it was a huge challenge over-the-counter selling antibiotics without prescription from a doctor, mainly private pharmacies, outnumbered in every corner. But the last 2 or 3 years, there is a real change, positive change in reduction of these phenomenon, but which is very good news. But we would like to have zero tolerance for dispensing antibiotic without prescription. The solution is to increase number of pharmaceutical inspectors, because we have so-called pharmaceutical inspectors, and they can put some order. But also the fines should be much more. If there is no other way to understand, then you have to use all possible tools that you have. I mean, you can use carrot, but sometimes you can use another part to have fines that will make them awareable and will change that practice.
Yeah.
So
no, thanks a lot. Yeah. I think we'll wrap it up at that. But before we close out, I think we have an announcement about our next webinar, and I'll pass this over to Chika to do that.
Sorry, I was speaking to myself. So thank you everyone for joining this webinar. We're grateful and thankful that each month you're showing up, and we're grateful for that. So we have an upcoming webinar on the 5th of May from 11 to 12 o'clock UK time. It's her name is Anne Odlin-Smith. She's a designer, an educator, and a director of design science. She has over 25 years of experience in design communication, and she has worked with intersections of science, healthcare, education to address widespread gap in effective communication design. So she'll be sharing her own point of view from design intervention that works and how applying this design helps in tackling AMR. So if you're new here and you are not part of the network or would like to be kept in the loop of what we're doing, you can scan the QR code so that you can receive updates and upcoming events as we share them. Thank you so very much for joining the session, and have a wonderful day.
Yeah, and thanks again to our speakers, Professor Raka and Dr. Hoxha. Much appreciated. Have a nice day wherever you are.
It was
Bye,
a pleasure.
Thank you.
Thank you for the invitation. Bye-bye. Thank you.
Bye.
Bye now.